Good morning, Madhu. Good morning.
Morning, Kaur. Last week you couldn't come, no?
Last week, I don't remember now. No, I have a memory problem also. Each week is same. There's no difference. Week after week after week.
How is the situation there in Hyderabad?
At this time, it's very bad.
Here also it's very bad. Here Saturdays and Sundays are lockdown in Kerala. 2 days week.
But right now, it is very bad. Many doctors are admitted. Hospitals, there's no bed. There's no oxygen. Is it same in Kerala?
Same, but oxygen shortage is not that much, but almost the same. Beds are all full. There is no vacant bed in the hospital.
Do you think this wave will subside or it will last? What do you think?
Totally unpredictable, Subhash. Totally unpredictable. We never thought that this will come up to this extent now, the second wave. Initially, we were happy that it came down. Now it is going worse. One thing is that people stopped caring about it now.
Yeah.
They let it come, whatever that side to that thing.
That's true. General public is still, if you go outside, they are as usual, as they were before.
Yeah, as before only.
So I think we have 23 participants. I think, Madhu, if you're okay, you can start.
3 participants?
23.
23. Shall we start?
I think so. They will keep on increasing.
Yeah, okay, we'll start. So good morning, everyone. This is the 26th session of our challenging case series. So I will start with the start my screen sharing. Okay. As usual, I will show 2 short cases, ultra short cases before going to the real challenging case.
Sir, sorry to interrupt. If you can move the laptop lid a little below.
Is it now? Okay.
Yes. A little above, sir.
Like this?
Yes. Perfect.
Okay.
Manasi, good morning.
Good morning, sir. How are you, sir?
Good. You're in Bombay, no?
Yes, sir. Bombay.
How is Bombay COVID?
Oh, it is all bad. We are all in a lockdown. Weekends, like sir mentioned, that there is a lot of cases going on, and the weekend curfew. There's a complete curfew on the weekends since the last 3 weekends, if I'm not wrong.
Okay, sir.
Yeah.
Madhu, please.
Yeah. Now, this is a very short case. What does this child show? You can see the video of the child. She's asked to hyperventilate.
Valike. Valcho. Valike.
And that's the thing which she gets. So every 5 to 10 minutes, this is recurring every day. When she plays and walks about, it comes even with the hyperventilation. So, anyone would like to voice their opinion as to what it is?
I think it's a tick.
Yeah. Yeah, anyone can. This is not a very simple, it's a straightforward case. I'll start with the simple case. Yes, anyone?
Sir, those moments are occurring only after hyperventilating, sir. What is doing it is hyperventilation.
It otherwise also it occurs very frequently, but during hyperventilation it is precipitated.
Okay, sir. Isn't there myoclonic absences, sir?
Yeah, exactly. This is myoclonic absences. Now, the important to realize is that unlike other absences, which are easy to treat, this is very, very resistant to treatment. This child had been on multiple AADs, starting sodium valproate, lamotrigine, levetiracetam. Still, there was no Even I started on epoximide without much benefit for this improvement. There's mild improvement, but never totally under control.
Madhu, is she losing her consciousness or contact during this?
No, in fact, too short. Now you can't assess whether she's really losing consciousness or not.
So then how are you sure it's an absence?
Yeah, if we're looking at eyes, no, this is at her eyes at that moment, she has got loss of awareness. She says she's conscious, but actually she's constantly losing consciousness.
Okay.
But EEG was showing typical absence effects. Okay, I'll go to the next short case. Again, another involuntary movement. This 60-year-old diabetic lady was admitted in the ICU with altered sensorium. She was noticed as some abnormal movements of the abdomen, and that is why I was called to see the patient. And this is what I saw in the patient's abdomen. Yes, it's a rudder-like movements of the abdominal wall.
കയ്യിന്ന് മുമ്പോട്ട് വയ്ക്കുക ഇവിടെ സപ്പോർട്ട് കൊടുത്താൽ മതി വെച്ചാൽ എനിക്ക് രണ്ടും കാണാൻ വേണ്ടിയിട്ടേ.
And at the hand also, some key movements of the hands also occurring simultaneously. Abdomen-like movements occurring in the hand and also in the left leg. Now, what do you think about that movement? Anyone? You want to see the video once again? I will show. At the normal factor.
കയ്യിന്ന് മുമ്പോട്ട് വയ്ക്കുക ഇവിടെ സപ്പോർട്ട് കൊടുത്താൽ മതി വെച്ചാൽ എനിക്ക് രണ്ടും കാണാൻ വേണ്ടിയിട്ടേ.
Anyone would like to comment about what it is?
Sir, it's a focal seizure, sir.
Yeah, it's exactly. What do you think would have been is continuously occurring?
Hyperglycemia related.
Yeah, exactly. This patient had, what is it? It's exactly correct. She had hyperosmolar state and the involuntary movement subsided totally with normal infusion. So it's recurrency. No, nowadays I don't give any anticonvulsants for these conditions. It just correct with fluid. These movements, involuntary movement will disappear. No, only thing, just to remind you that the diabetic hyperosmolar state can take many type of abnormal movement. They can produce obsotonus, they can produce myoclonus, they can produce this kind of jerky movements affecting the limb. Only transient episodes awareness may be there with automatism, some Swimby Lake state recurrently coming. So all these can be manifestations of hyperosmolar state.
But Madhu, if this patient had only abdominal movements, and if suppose she did not,
she had abdominal movement, and along with there some tremor-like movement of the hand and the leg.
No, my question is: suppose I'm giving a hypothetical situation. If this patient came only with abdominal movements and did not have any arm or leg movements,
yeah, we should keep that possibility, because recurrent focal seizures can be confined to any body part in diabetic hyperosmolar state.
So, sometimes I have seen some patients who are having just selective abdominal myoclonus, selective, nothing else, and which goes on for days together.
Yeah,
can that also be seizure?
Yeah, it can be. Okay. Another classic example that they can present with hemianopia only. Episodic hemianopia without any head deviation. That's a manifestation of diabetic hyperosmolar state. It's also, as a negative type of seizure also can occur in hyperosmolar. Okay. Now we'll go to the real case. It's a good case. This case is given by Dr. Roy Thomas, who is in Medical College, HOD. This is a story of a 50-year-old woman who presented with history of seeing images moving up and down as if a film is moving up. That is the word he used, film is moving up. This has been there for the last 1 month. She said that when she was looking at me, she saw my head moving up and down. This symptom was present while at rest as well as while walking. It is present with binocular and monocular vision. Even if it closed one eye, that persists. It was more when she looked at a distant object than the near object. There was no headache, no vertigo, any other terminal symptoms. For the same duration, she also noticed tremendous movement of her left hand. It was more while she was holding an object. There was no walking difficulty. Now, this is the history of the patient, which you may not understand, but from the action, from the gestures, you can find what she's trying to control. It's moving up and down like that. It's like it like that.
എൻ്റെ തല മുകളിലോട്ട് താഴോട്ടാണ് എന്നെ കാണുന്നത്. എൻ്റെ നടക്കുമ്പോഴൊക്കെയാണ് എൻ്റെ മുഖം ആടിക്കൊണ്ടിരിക്കുകയാണ് മുകളിൽ താഴോട്ട്.
And when you close one eye also, yeah. Close one eye also. She also noticed tremulous left hand on assume certain postures. Okay, I'll come to the proper examination. This patient had nystagmus, a rhythmic vertical up and down movement with equal velocity. It's a pendular nystagmus in a vertical direction.
ഇനി അടുത്ത് നോക്കുമ്പോൾ
It is present on looking more. It is more on looking at distant objects. It is present on looking up, looking down, looking laterally. In all directions, it is persisting.
ഇവിടെ നോക്കുമ്പോൾ
I don't know whether you can make out the movement.
ഫ്രണ്ടിൽ തന്നെ നോക്കേ, കണ്ടല്ലോ അമ്മ. ഇനി നോക്കേ, ഇവിടെ നോക്കേ.
The ocular movements are all normal.
ഇനി ദൂരെ ആ ഭിത്തിയിലോട്ട് നോക്ക്, മുകളിൽ എവിടെയെങ്കിലും നോക്കുക. ഇനി മുകളിലോട്ട് നോക്കുമ്പോൾ താഴെ
Okay, that's all normal.
ഈ നാക്ക് നീട്ട്.
Okay, that's all normal.
മാസ്ക് ഇട്ടു, മാസ്ക് ഇട്ടു.
Tone power normal is the upper limb. There's no incontinence to the left, right upper limb, but there was gross incontinence to the left upper. That she did with it. Lower limb power was normal, both proximal and distal. And the lower limb was not much incontinence to the relatively okay. You can call it really abnormal. She was doing it fairly well. The reflexes are all brisk. Biceps supinator, biceps TFS are all brisk. Ejects were brisk, and ejects are also brisk. And plantar was upgoing bilaterally. Sensations were all normal, vibration was normal. There's no pain on either side. Conscience normal. And twisting rhomboidism, even with feet close to a unsteady, it got activated by closing action. She walks with slightly broad-based, hesitant gait.
തിരിച്ച് നടന്നേക്കണം, തിരിച്ച് വാ, തിരിച്ച് നടന്നേ, തിരിച്ച് നടക്കമ്മ, വീട് നടക്കാൻ നോക്കി, നടന്നോ, നടന്നേ.
Hesitant gait probably may be due to her epilepsy as well.
ഇനി നടന്നേ, ഇനി തിരിഞ്ഞ് നടക്കും, നീ കണ്ണടച്ച് നടന്നേ.
So this was the story of the So what are the findings? She has binocular vertical pendular nystagmus. In all directions. It's more when patient is a distant object, did not change with gaze direction, and extraocular movements was normal. Rest of the cranials were normal. The motor system, tone power normal in both upper and lower limbs. All DTRs were brisk and are upgoing bilateral. She had left-sided finger-nose incoordination. Illusion test was normal. Sensory system was normal. Broad-based slow gait, and there is Romberg's rate as positive. Now, this is the findings. So, the questions are: one, what is the type of, where is the localization, and what is the likely etiology? Let's first to the first question: what is the type of nystagmus patient is having? Anyone?
So pendular nystagmus.
Yeah, it's a pendular nystagmus. The commonest cause of pendular nystagmus is congenital. Is it that she's got a congenital pendular nystagmus?
Most probably acquired, sir, because she's complaining of symptoms recently.
Yeah, the symptom is oscillopsia. See, oscillopsia will never occur with a congenital pendular. Congenital nystagmus will not produce oscillopsia. If you find oscillopsia, and that is more common with pendular nystagmus than with nystagmus, that indicates it's acquired pendular nystagmus. Anyone with oscillopsia and pendular nystagmus, it's acquired. That is point number one. Sometimes the oscillopsia can be unilateral confined to one eye, where you can occur central lesions, but you have to keep the possibility of a superior oblique myopathy in the situation. That is why you have to look for oscillopsia or look for nystagmus by closing one eye or not. So it's acquired vertical pendular nystagmus. This can affect one or both eyes, can occur in any axis. This is the site of lesion for the acquired pendular nystagmus, that is the ilion-molar triangle, and they affect the central tegmental tract. This is the waveform. Now, what are the causes of acquired pendular nystagmus? These I have taken from literature. It can be due to disorders of the central myelin, like multiple sclerosis, Cockayne syndrome, and pernicious Spastic syndrome, paroxysmal disorders, and toluene abuse, all producing a disorder. Can also occur due to visual loss, also occur oculoparietal tremor, that's one which occurs in ilion-molar triangle. Now, occur with inferior olivary hypertrophy, and all this is a part of that. Ocular movement can be part of that. Other causes include acquired brainstem stroke, Alexandrian cerebral Whipple's disease, hypoxic encephalopathy, neurosarcoidosis, serotonin syndrome, and diphenhydramine toxicity. Next question is, what is the likelihood of the patient? We know she has got pendular nystagmus, bipyramidal signs, left incoordinate left upper limb indicating a dentative rubro outflow tract involvement, and Romberg is slightly positive, may indicate some gait ataxia may be there, but there is no sensory loss in this patient. It's a sensory ataxia, and these are the findings.
Demyelination may be one first possibility, sir.
Yeah, so the site of lesion is the brainstem, which is affecting the central tegmental tract, affecting the nucleus with inferior nucleus. By that, cerebral tract is affected, and then the outflow tract is affected on the left side. Possible sites involved. So demyelination is one possibility, but duration is about 2 more. Usually demyelination lasts less than 1 month. Any other possibility you want to keep in mind?
Paraneoplastic or vasculitis.
Yeah, it can. Why not neoplastic itself? Neoplastic itself you have to keep in mind. It is progressing over 2 months' time. Okay, the other so these are the possibilities we considered for the granuloma. Brainstem demyelination, as you said, like NMO syndrome, which affects the pondine region, which can produce this brainstem manifestation of subacute onset. And paraneoplastic autoimmune brainstem itself. Like these are the possibilities we thought the patient might. So with that in mind, what investigation you need?
Brain MRI.
MRI. So this is the patient came with this MRI. That is normal. This flare sequence is normal. This hyperintensity within the parameters is satisfactory. This is the SWI normal. This is the diffusion weighted sequence, again normal tones. Hemisphere normal. Angio is a poor quality, but it was whatever the pictures were, large vessels appears normal. Okay, also with the cervical MRI spine, that's also normal. Now, what do you want?
Contrast MRI.
So I thought we would have, I wanted a thin cut to the brainstem because I was sure there's lesions in the brainstem, but it is not seen there. So I thought that a 3D flare along with contrast. This is what we did. Again, repeat the sequence. This is the ordinary flare. This is a 3D flare sequence, thin cuts. That did not show any lesion in the brainstem, to our surprise. This is a 3D flare sequence. So contrast was done. There was no contrast enhancement anywhere in the brain.
CSF analysis, sir.
Yeah, in fact, I wanted 2 things, CSF as well as paraneoplastic antibody. So in fact, they wanted to go to a higher center, Sriyatra they went. They did the same. CSF was normal. And the paraneoplastic antibody showed anti-SIG4 antibody. I'm hearing the antibody for the first time, and the SIG4 antibody was positive. So this is what is this antibody? In patient neurological symptoms of unknown cause, detection of SIG4 antibodies predict a neoplasm, usually small cell lung carcinoma, and suggests that the neurological disorder is paraneoplastic. So this antibody is highly suggestive of a paraneoplastic syndrome. Unlike certain other antibodies like VJKC and AMBA, they can lead to other conditions as well. Detection of SIG4 antibodies are often associated with anti-Q or CRMB antibodies. And patients with isolated SIG4 antibodies are more likely to develop cerebellar dysfunction than those with concurrent immunities. This is another case report of isolated SIG4 antibodies in paraneoplastic cerebellar syndrome with an underlying ovarian tumor. Usually it is a small cell lung carcinoma, but can also occur with ovarian tumor. So what we did the MRI of the CT just was there. He showed a well-defined enhancing irregular lesion with speculations, the anterior segment of the right lobe, abutting a minor fissure with a fissural thickening. There was also a well-defined enhancing lesion in the right adrenal gland, feature suggestive of right lung malignant lesion with mediastinal lymph node and right adrenal metastasis. Incidentally, there was also a solid cystic lesion in the ovary, which whether it's malignant or not, we do not know. So this is the story of the patient. So the final diagnosis, anti-SIG4 antibody positive, paraneoplastic brainstem encephalitis, secondary to CA. So any questions?
Sir, this antibody is routinely done, or how to suspect this and how to send this one, sir?
In fact, I did not do we sent a panel for antibodies. I don't think in the panel SIG4 antibody was done. Maybe an extended panel, if you do, you can pick up this antibody. The thing is, those coming cerebellar syndrome, make it a point to do, in addition to the routine paraneoplastic antibody, also do anti-SIG4 antibody. That is highly specific. The The syndrome is specific for a cerebellar impairment. Yeah, any questions? Any other questions in this case?
This zigzag eye movement is because of the pendular nystagmus.
Yeah, this is pendular nystagmus causing the vertical orthodoxia. That is why stealing in my head is seen always moving up and down constantly. It's because of the pendular. If it is due to the same area cannot and parietal nystagmus or parietal tremor, as well as branchial nystagmus affecting the larynx. Even axial muscles can also produce rhythmic movements.
Madhu,
Okay.
what was the age of this patient?
She is about 50s. She's otherwise doesn't look like a male at all. It's perfectly healthy at all. Only but that's why she came.
So this was PET also done in this patient?
No, PET was not done because the patient was, once he's seen this thing, she was sent to RCC for further nothing. They want to take a biopsy from the lung lesion and go further.
Yeah, I mean, yeah, correct.
Sir, many such patients will come, sir. Many times we end up paraneoplastic profile being normal. Sir, you usually proceed with investigating for paraneoplastic, sir, or
Yeah,
treating.
in that situation, what as Professor Cole said, the ideal thing will be a PET CT to find out any malignant lesion anywhere in the body. But that can pick out the hypermetabolic. But that cannot differentiate, so for example, neurosarcoidosis. The thing we know our system is sarcoidosis, we can differentiate. At least we know other organs are affected, then we can proceed further. Under these conditions, when the patient the paraneoplastic syndrome, to find out where the malignant lesion is, PET CT is ideal. We previously we used to do CT chest abdomen, ultrasound, the thyroid, ultrasound testing, and better than that, we PET CT. You can find out many things.
Okay, sir. Okay.
Madhu, in your experience, when patients come at 50 years with this kind of cerebral ataxia, what is your experience? What are the most common etiology? Leaving alone this patient, what is your?
In the case of the usual thing which you are depending upon the duration, if it's a long duration, invariably they turn out to be some degenerative condition. But subacute presentation, as you can see here, I have seen case with anti-GAD antibodies quite common. Then paraneoplastic syndrome is also not very uncommon. Then I found the other things, the other common condition of subacute ataxia is demyelinating disease, subacute demyelination. These are the things I come across. Mercer syndromes are all, even the textbook says uncommon.
Yeah.
Sir, if the antibody, paraneoplastic antibody is negative, then better do to CT chest abdomen or go with PET scan, sir?
Yeah, you should go with PET scan. The antibody need not always be present all the time.
If you don't have any clue, then I think it's always better to do a whole body PET.
Yeah.
Because many times it will come from the most unexpected source.
Exactly.
Which you can never diagnose clinically. But don't think that you will do a PET and every time you will get something. Majority of the time PET will be normal, but some you may pick. In some cases you may pick which you cannot afford to miss. So I think the other thing is, if there are any postgraduates here, is that you should always think of at this age, when a person comes for the first time with a cerebral ataxia, think of degeneration. And degeneration, the first one you should think at this stage is a multiple system atrophy of a cerebellar type. So look for the other things also. Look for the autonomic changes, look for the bladder, which may not be so obvious, but we have to look for that. And of course, it can be a late presentation of a spinocerebral ataxia, which has got 30-40%, but it will be a late presentation. But of course, we have to rule out these neoplastic. That's very important. But many times it's a bugbear. Sometimes we just can't find a clue. What is the cause? And what do you say, Madhu? In some cases,
absolutely correct. Now, one more case I have seen with subacute ataxia is CJD. which can present sometimes with the pure cerebellar syndrome to begin with, before they go on to develop myoclonus and hypercognitive. So
and we keep on talking about hypothyroidism as a cause of ataxia, cerebral ataxia. Is that how common it is in the reality?
I've never seen one. Frankly speaking, I've never seen one.
Yeah. And what about Hashimoto's? Do you
Hashimoto-
consider autoimmune? Autoimmune would be the same, what you said, those glide and antibodies or like that.
Right. In a celiac disease, they are all described in the textbook. I have not seen. Practically, I have not seen.
Yeah, but it is worth, in neurology, we always say anything treatable, even if we have to go to any length.
Celiac disease, Hashimoto's, absolutely correct.
Yes, sir. Yes, sir. Thanks, Madhu.
Oh, thank you. Thank you. Shall I go to the next case now?
Yes, sir.
Okay. This will be a more straightforward case, but interesting case. Interesting presentation. A 60-year-old female is admitted with history of loosening of her chapels without her awareness for the last 4 months. She has progressive difficulty in walking in the form of unsteadiness. There is incontinence of urine for the last 3 months and became bedbound in 3 weeks' time. So in 4 months' time, she became bedbound. So that means it started with loosening of the chapels without awareness, unsteadiness in walking, urinary incontinence, and then becoming bedbound because of severe inability to walk. There is no history of any sensory complaint or sphincter problems. So this is the video of the patient. The power was normal, but she has got finger nose incontinence. Each was normal. They keep your hands upright, eyes closed, slowly come down. Make it obvious when you make a bit. Option 4 was normal. Those sentences appear weak, but one should be very careful telling it is weak to the patient's got a proprioceptive loss. You do not know where the feet is. So all the patients always ask the people, look at the feet and then do the examination. Here appears weak, but I am not very sure because she does not know where the feet is. Consequences are all known. Look at the lower limb, she does not know where the limb is. She just fumbling with the feet to place it correctly. The reflexes are all well elicitable on the brisk side. Brisk reflexes. Lower limb reflexes are also angles will be. Manner was indefinite. Preparation is embedded in the feet, in the hands. It's not able to feel there. There's feeling little bit on the wrist, but on the fingers is totally absent. The lower limbs is not able to feel over the knee, not able to feel in the anterior expansion. No. This again is a no vibration. When you put on the sternum, she said yes, she's able to feel it. It's lost up to above the ear.
കീഴേ മുകളിലാണ് ചൊല്ലണം.
Joint sense is impaired in the lower. Totally not the
മുകളിൽ ഇപ്പൊ അനക്കനെ തെരിയില്ല, അനക്കനെ അനക്കില്ല.
It does not even feel the movement of the
ഒന്നുകൂടെ എന്ത് ചെയ്യും,
and it is sit up. Well, sitting up also tends to fall backward. Keeping an outstretched, which is good of the person. Both hands comes down more on the hand. So look at the front. She sways back and towards the right leg. She cannot make her foot swing. Probably because her progressive been lost from the prime muscle aspect. That is, she loses balance when the closes right. And she cannot even stand because of severe ataxia. It slips off. And I have to support the feet from moving forward. The feet goes into awkward position because power is not the awkward position because the total losses. The feet. It does not bear their feet. So findings were tailors are all normal. Motor system power, upper limbs normal. Lower limbs state 4 power, the dose present feet whether present or not we are not very sure. Detail, however, all are brisk. Pandas are indefinite. Sensory impaired vibration on both hands and the lower limbs and is impaired up to above the iliac, not up to above the iliac crest, but able to feel over the sternum. Severe ataxia which is likely to be sensory and sensory idea of the tongue muscles causing imbalance when the patient closes eyes. So summarizing, she has got severe sensory ataxia but is unable to stand, walk or even sit. There is truncal swaying while sitting. The dietetic history, she patient is a non-vegetarian, not on any drugs except for Ayurvedic medication. Total urination is 4 months. So what do you think is a site of lesion and exercise?
The first possibility is involvement of the cervical cord in view of impaired vibration up to the iliac crest with severe ataxia and brisk reflexes.
Every is also lost in the hand also. Probably even in the tongue is also lost. But I had not checked it. I should have checked the spine, but I did not do that. Yeah. So the west side of the sensory attacks, which is the peripheral nerves or in the where roots or where do you want to prostrate?
First possibility the posterior column, sir.
Yeah. Why? Because the reflexes are all brisk. Which had been a peripheral neuropathy ataxia or a ganglion neuropathy sensory ataxia or a polysensory radiculopathy sensory ataxia, we expect reflexes to be lost. So here the reflexes are all well intact on the brisk side. So telling you that more likely has to be in the posterior column post severe sensory ataxia. That is the cervical cord because the upper limbs are also got incoordination. In fact, sometimes you may mistake it for cerebellar involvement because incoordination is so severe in sensory ataxia, it can mimic cerebellar. The only true clue is that severe sensory ataxia can exactly mimic cerebellar ataxia affecting the upper and lower limb. But the true clue is that sensory ataxia will not produce dysarthria, will not produce any nystagmus. In fact, these are the only 2 signs by which we can definitely say it is cerebellar and not sensory. The patient has no sensory complaint per se. It's a negative symptom in this patient. Okay, then the other tract affected is the most likely pyramidal tract is also affected because of the brisk reflex the patient has. Probably there is some associated weakness of the wrist muscles also. So what investigation need? The blood routine, everything was normal, lipid profile normal. Then what do you need now? NCV?
Cervical MRI, NCV and B12, sir.
Right. So NCV was done, which is upper limb motor conduction normal. FF latency is normal. And this NCV in the lower limb shows inelicitable right superficial peroneum. Other stabs are all normal. So how do you interpret this sensory finding? One thing it is, even though it is there, is totally unrelated because this isolated superficial sensory loss cannot explain such a severe sensory attacks in this patient. So it cannot be not significant. Probably due to the technical difficulty, we are not able to get it. So for all practical purposes, conduction is sensory conduction is normal. So ultrasound abdomen was taken normal. ANA profile showed positive SSA antibody. You want MRI, no? Okay. What does the MRI show?
Dorsal column hyperintensity, sir.
The dorsal perfectly is the dorsal column hyperintensity you can see. But it's a little more anterior also, not only the dorsal column per se. And if you look carefully, the hyperintensity is not only in the posterior part, but also involved in the pyramidal part. See, the whole posterior part is hyperintense. Posterior column and lateral column. So it's a posterolateral, there's a degeneration. Usually, it's not the classical appearance FC you find only in the posterior column, like our rabbit ear appearance. But this is a little more extensive effect in the pyramidal tract. Again, you can find out the pyramidal tract as well as posterior column is affected. Brain MRI was normal. So, the diagnosis is
B12.
B12 deficiency, 141. And patient improved, could not improve only partially with B12 supplementation because of the extensive damage must have occurred by that. Why she went into such severe this thing, we don't know. Why, in 4 months' time, she became usually by B12 deficiency slightly more prolonged than the 4 months duration, but it's such a severe sensory attacks. It's a straightforward diagnosis, but still I wanted to tell you that usually in SCD you find some evidence of paraneoplastic as well. Because even though they got posterior column dominance, some peripheral neuropathy also will be there. But this patient did not have evidence of peripheral neuropathy. Any questions?
And she did not have a sensory neuropathy also.
No sensory neuropathy. Clinically also not there. And primary modalities were normal. Vibration is the only thing which is affected.
And planters were also downgoing, even though reflexive were brisk.
Yeah, we are not said was indifferent. It's neither upgoing nor downgoing.
Yeah, so I think that's a very important message.
Yeah.
You may not have all the components as are taught to us traditionally.
Exactly. Exactly.
So that sign, I think, it's called trident sign, no? On MRI, I think.
Yeah, something like a trident sign.
Trident sign.
Yeah, but not the typical trident, but something like a trident sign. Correct. But that's usually better seen in contrast MRI rather than in deteriorated trident sign.
The incontinence is a bit unusual, sir.
Pardon?
Incontinence.
Yeah, no, that can occur because that is with the pressure of the bipyramidal tract. They can have incontinence of urine. So bipyramidalization can produce incontinence. In fact, we must have all seen commonly posterior column involvement of sensory attacks. But these patients can have predominant spasticity also. SCD can, some of them can produce predominant spasticity with mild pyramidal. That's also possible. Here in this patient, actually there is pyramidal involvement. Even though there is not much weakness, the reflexes are all brisk and you find hyperintensity in the lateral column also.
Sir, in this patient, SSA was strongly positive, sir. 52 was there. 3 plus.
Yeah, I do not know how to explain that thing. See, many times, this antibody, autoimmune antibody, can be present otherwise non-medial also. For example, if you take multiple sclerosis, you find 30% of them can show all these antibodies may be positive. So how much BSCT can be? It's clinically correlated. We should not give any much importance.
Okay, sir.
So B12 is predominantly myeloneuropathy, but in this case there is predominant myelopathy with almost no neuropathy. Sir.
Exactly. That's a no. In fact, there's a condition producing B12 dysfunction due to that is methylene tetrahydrofolate deficiency syndrome and congenital B12 metabolism syndromes. They can present pure pyramidal neuropathy without any sensory ataxia, without any neuropathy. Only spastic syndrome due to this particular gene mutation. So this called white. There are also other things which we call. One is that the methylene tetrahydrofolate deficiency syndrome, and another one more thing is there we say can produce this only pyramidal syndrome.
Did this patient have anemia also, Madhu?
No, this patient did not have any anemia. Anemia, yeah, borderline anemia was 1.5. Yeah, there was anemia also. The count was also anemia, but the peripheral smear was normal. The RB that 9.2 or 2.96 is there.
9.2.
Okay.
Now, the other question I would like to ask you, Madhu, is that there was a once I came across some literature in which it was said that in B12 deficiency, sometimes the serum B12 level may not be that low. Like in your case, it is 141. Sometimes it may even be 340, 350, and yet the patient may be having B12.
In fact, it can be high. In fact, one of the cases which I showed 2-3 weeks back, patient had B12 of 1000 and the value was 1000. Patient had B12 deficiency.
So how can we find out that?
Yeah, this is the same question was asked by some other people the last time. In fact, I found out the literature, I kept it with the same laptop. They say that there's a problem in estimation of vitamin B12. It can be low, normal, even high in person with B12 deficiency. So the ideal test to do to find out B12 deficiency is either homocysteine level or more specifically methylmalonic acid level. Methylmalonic acid level is very difficult to do, but always go for serum homocysteine.
Yeah.
Yeah, the last case which I showed with sensory neuropathy as well as post-traumatic ataxia with hyperdensity in the cord had an elevated B12 level.
Yeah.
The homocysteine was low.
Yeah, Madhu. Sure. Thanks.
Okay. Now we'll go to the next case.
Yes, sir.
Yeah.
Dr. Kebuch here. I wanted to comment on the previous case.
Yeah, please.
I have had two patients of subacute cerebellar degeneration, sporadic, who had turned out to have antigliadin antibodies positive. And both of them did well. One patient after IVIG and the diet for celiac had actually improved to near normal, and the second one has stabilized. So it is always worth checking for antigliadin antibodies in sporadic.
Exactly. What you said is perfect. Right? Celiac disease is one of the they always mention, but I don't say that. Any other comments you'd like to make, anyone? Okay, then we'll go to the next case. It's a 44-year-old lady with imbalance while walking, as well as numbness of both hands and feet. The complaints are gradually progressing. There was no root pain, no bladder problem. This is the video of the patient. The motor core was normal in the upper. Tone is normal. The lower limbs were rusty. There's hypertonia. Motor core was normal motor core. Under the reflex, all reflex are diminished in upper limb except right tricep. That is well elicitable. It's also elicitable, but not as a let's say that but left is more diminished than the right side. Both finger pressure reflects the answer. Early ejects are brisk, and you're also brisk, but not as brisk as. Matters are indifferent. The tone was fast. Vibration sense was normal.
അറിയുന്നുണ്ട് ഇപ്പോഴോ ഉണ്ട് ഇപ്പോഴേ ഉണ്ട് ഇപ്പോഴും ഉണ്ട് ഇത് താഴെ മുകളിലൊന്ന്
No, but joint sense is impaired over both feet.
ഇത് പറഞ്ഞില്ല ശരി എഴുന്നേറ്റ്
Just got positive number. Eight path. Okay, so where is summarizing the finding? Tone normal in the upper limb, in the lower limb. Power normal in upper and lower limbs. DTR, all DTR in the upper limbs were decreased except both prices more on the right side. More well elicited on the right side. Lower limb, both inject are brisk, angelics are also brisk, but less compared to that of the inject. Pandas were indefinite. Sensory impaired vibration and joint sense over both feet. First, upper limbs were normal. Thrombus it was mildly positive. It is positive. So, where is the site of lesion? Anyone can unmute and say? Any pages like to say where is the site of lesion this patient?
First possibility, the cervical levels in view of absent diminished reflexes in the upper limbs and brisk reflexes in the lower limb with spasticity.
Yeah, this one undoubtedly there is pyramidal involvement in the lower limb, and therefore impaired vibration joint sense can be either due to peripheral nerve or due to the posterior column. Since the reflex angiodex are really elicitable, more likely to be in the posterior column. And the level is given by the axial reflex in the upper limbs, because in the spastic lower limb, there is no reason why the upper limb reflex should be diminished if the lesion is above the cervical column. Reflex C5, C6 is the maximum definition. Triceps are well elicited, probably that is the site of lesion in this patient. Okay, C5, C6. The triceps is well elicitable. Finger flexion may not be all the time well elicited. May not sometimes also it can not be elicited all the time. So the cleaver level more likely C5, C6 radiculomyelopathy. Agreed with me?
Yes, sir.
Okay. So let us see any odd points. But but slightly uncommon, less common is that in cervical myelopathy and C5, C6 cervical myelopathies, the sensory symptoms first start in the upper limb rather than the lower limb first. And that too in the little finger, middle part of the hand. This is seen in 70 to 80%, but in 20% that can start in the lower limb. That's not against that. Because the gracilis tract is more medial and inside than the cuneatus tract. So when there is a compressive lesion from outside, this applicable about the cervical classical spondylotic radiculomyelopathy. It is a cuneate tract which is larger and bulky, more liable to get compressed than the gracilis tract. So they usually start with upper limb symptomatology to start with. That's not a real odd point, but can occur. But I thought it's little odd in this case. So you want MRI, no? MRI showed a C5, C6 disc collapse. You can see find out here some hyperdensity within the cord. I'll show you a better picture. You can see the coronal cut showing the hyperdensity within the cord. This is C3, C4 level and C4 level, not much compression of the cord. Same level. Now look at the C5, C6 level. There is a disc compressing the cord and the cord is flattened. Again, it is flattened here with calcified disc here, material causing compression. There's also significant compression you can see at that level. So do you want any other investigation in this patient? Or what would you like to do with this investigation? Send her for surgery or not? Anyone? In fact, this
Contrast study, sir, in the cervical.
pardon, surgery.
Contrast study, sir. Contrast study in the cervical.
Why? What do you want contrast? We can see already seeing a disc and got a compression of the cord, hypersensitive in the contrast. Okay, that is disc is calcified also. That may not be useful.
Okay, sir.
So in fact, I did a nerve conduction was normal because I did it only because that the sensory loss in the upper limb start with little off. That's the only thing. But I don't. That's the only thing. Am I audible to you now?
Yes, sir.
Yeah, something happened in between. That's the connection went away. Now I'll start sharing my screen once again. So this is where we left. So what will you like to do now in this patient? Conduction was normal, MRI showing the finding. Surgery? Hello?
So wait and watch for a couple of weeks.
Okay. But when there's a cord lesion, actually, ideally the patient should be subject to surgery. Now let's see what happened to this patient. Her father and brother were having the same disease. They were also having walking difficulty. So this is elder brother who accompanied the patient, examined him. Let's see what is happening. He also got the exactly same time. Early was Spastic, upper movement. But he had in addition, early was Spastic. The weakness was present. And ages were risk, just like their sister, but angle checks were absent. There is impaired sensation, just like the sister, impaired sensation of vibration and joints.
ഇതിന്റെ മുകളിൽ താഴെ പറയണം ഇപ്പൊ അറിയുന്നില്ല അറിയാവോ താഴെ മുകളിലോ അറിഞ്ഞൂടാ. ഇപ്പോഴോ? ഓക്കെ. ഈ വൈബ്രേഷൻ അറിയാവോ? ഇപ്പോഴും ഇല്ല. എഴുന്നേറ്റോ.
It is also but also what's exactly like this?
സ്പീഡ് നടന്നു.
It's a father also.
ഒന്നുകൂടെ സ്പീഡ് കൂട്ടിക്ക്. സ്പീഡ് നടന്നു. ഓക്കെ, മതി.
No, what do you think that what is happening in the what is the condition is? Only difference between our index patient and this patient, the elder brother, is that the elder brother had absent angle checks. The sister did not have. His NCV motor conduction was normal. Sorry, not normal. The lower limb right peroneal amplitude has decreased, but depth peroneal is 7. We do not know the previous values. It may or may not be affected. FF latency is prolonged in both peroneal and tibial. And sensory conduction in the lower limb was normal, even though patient had impaired sensation. An angle check in this patient. So, what is final diagnosis? What do you think the patient is having? Now, will you submit up for surgery or what?
No, sir. Maybe HSP variant, sir.
So here there is a radiculopathy, cervical radiculopathy is there in this patient, caused by the spondylotic myelopathy, and mild cord involvement. But the finding of pyramidal tract involved in the lower limb and the posterior column involvement might have been due to the HSP plus. Probably in addition, there's radiculopathy. So that means that the patient need not necessarily undergo a surgery. In otherwise, a sporadic case coming with spasticity and weakness of lower limb, surgery is indicated with the compression showing that level. So many times you find a compression of the cord, but that may not cause any significant disability at all to the patient. I have seen high marked degree of hypertensity with the cord, marked compression, otherwise perfectly normal, walking normal. Those patients does not need any surgery. So this may be like that. What is it is typically for HSP plus is the radiculopathy symptoms, C5 is absent and absent reflexes. So that alone need not warrant any surgery. So this is a very tricky case. If you are not seen the relatives, we would have thought the patient might have recurring everything for all due to cervical myelopathy and warranting surgery. So any questions?
Yeah, Madhu, but I agreed that it is HSP plus, but there is also additional compression on the cord, additional on top of that.
Exactly.
And if the surgery is done, maybe there is some improvement, 20%, 10%.
That's I agree with you, but we cannot assess because the so-called pyramidal weakness the patient has in this patient, is it due to part of the HSP syndrome or due to the compression? We can't say.
Can it be due to both?
Yeah, can be due to both. But how to know that surgeries will produce improvement in this patient? That's a question.
So maybe collar is better.
Yeah, that's
cervical collar.
Yeah, that's the problem.
And this radiculopathy is no. When we say HSP plus, that plus is what? What is plus in this?
Plus can be peripheral hematrophy, posterior column involvement, deafness, hoarseness. Many things can occur in that.
No, in this patient. In
this patient, the plus is got a sensory involvement. It's got angle check is absent and sensory impairment in the elder brother.
And these other family members were largely asymptomatic.
No, father was also affected.
I mean, significantly.
I did not see the father. Father is normal. It's the two siblings who came that they were affected the same.
Okay.
So it's a tricky case in this patient. Both things.
So any clue retrospectively for the index case to suspect whether it's HSP? The spasticity is predominant in that index patient.
Correct. Index patient spasticity is predominant. There's not weakness at all in that patient. That's what. But many times compressive myelopathy can behave like that. They can come with only spasticity without any obvious weakness. But my trouble was that the still symptom was confirmed. This clot for a because absent major canal, biceps supinator and all with no sensory complaint even in the upper limb. That is slightly odd, I thought. But that's not fun. It's at once, but 20% can start with sensory symptoms in the toe. Okay. Any other questions? Shall you stop here or continue with one more case?
One more case, obviously.
Okay, one more case. Okay. This is a 65-year-old man presented with difficulty in tying dhoti with his right hand for 18 months. Sorry for the spelling mistake. So dhoti, you cannot put the dhoti inside. This case was from Dr. Ajit Thomas from Pushpagiri. About 6 months later, he noticed difficulty in bringing his right hand to the mouth while eating food. He said he cannot bring it towards his mouth. For the last 8 months, he found difficulty in elevating his hand above his head. So first started with tying dhoti, then flexing the hand, then elevating the hand. For the last 4 months, he was unable to take water in his right hand and eat food because the water will seep through the between the feet. No combined pattern in the lower limb, no sensory or bladder problems. Okay, so progressive weakness was starting in the hand, then probably biceps, then elevated the shoulder, and the system must become further weakness, become worse over the last 4 months. This is the video of the patient.
ഫുള്ളായിട്ട് നാക്ക് അങ്ങോട്ടും ഇങ്ങോട്ടും തള്ളിക്ക്, ഇടത്തോട്ട് തള്ള, വലത്തോട്ട് മതി. കണ്ണ് മുറുക്കി അടച്ച് പല്ലി കാണിച്ച് ഈ അച്ഛാ ഈന്ന് കാണിക്കും. മതി മതി മതി.
The upper limb, there is wasting of the small muscles in the hand. Right. There was also wasting in the biceps, deltoid, pectoralis major, and scapular muscles shredded from. There was weakness in the biceps, deltoid. Biceps was not much weak, but they are also weak. Pectoralis is weak. Distal muscles are a little more better than the proximal muscles, but 4+. That was good power. Finger muscles are good power. Finger extensions were weak. Small muscles are good power. And introduction are good power. You can find out the aging in the pectoralis. The only muscle power, everything. Plasticity of both the body. When trying to get up, see the Babinski's thigh rising sign. The thigh gets up when it gets elevated when trying to get up. Bicep supinator reflex absent. Some suggestion of inverted supinator. Right side, not on the left side. Triceps also absent on the left side. Right side is this. Well inside. Finger pressure was elicited by this from the right side, but not on the left side. That is left side it is absent. Knee legs were brisk. Ankle legs were also brisk. Under was definitely not very sure about that. Top down reflex is visible but gets fatigued very easily. Still, it's present slightly on the right side, but fatigue.
ഇതറിയാമല്ലോ കിലുകിലുപ്പ് അറിയാവോ?
Sensations are all normal. Vibration, joints, everything. The only thing is the lower limb getting lifted up as she was passing. And she has got wasting with the infraspinatus, supraspinatus, able to elevate the shoulder, but gait is normal. The sparsity, it is not perceptible. So, there's a tongue perifasciculation, but no wasting. Wasting of both trapezius, supra infraspinatus, deltoid, biceps, but more than the right side, more on the right side. There's also wasting the triceps. I forgot to write that. Forearm muscles are not much wasting. Mild wasting of the small muscles of the hand. Tone normal in upper limb and spastic in the lower limb. Power, weakness of both deltoid, bicep, infraspinatus. About grade 3 on the right and grade 3 plus on the left side. Triceps grade 4 on the right, 4 plus on the left side. Weakness of the finger extensions and small muscles, but small muscles are much less affected. Finger extensions are also much less affected. But the affection is slightly more on the right side. Power in the lower limb now. Detail the upper limb, absent biceps and supinated bilaterally. The right triceps is 2 plus, left triceps is 1 plus. There is inverted supinated on the right. Finger flexion is brisk on the right, absent on the left side. Lower limb, knee and ankle touch brisk. Abdominal reflex can call it absent, but just irresistible in the one stroke, but subsequently gets fatigued in all quadrants. Pandas indefinite, sensory or normal, gait normal. So where is your localization?
So predominant motor involvement of LMN and human type, probably motor neuron disease is the first possibility in view of tongue fasciculations also.
Yeah, in view of that tongue fasciculation and absent sensory, there is no sensory finding at all in this patient. So I think it's a motor neuron disease, a possibility. Okay, anyone else would like to comment? Any other possibility?
Your C5 jerk biceps is absent.
Yeah, biceps
there may be some additional disease there.
But maybe that element finding that muscles are also more severely affected.
Yeah, that will.
Maximum element wasting and weaknesses the biceps, deltoid, and less in the triceps.
But you showed inverted supinator also.
Yeah, inverted supinator also.
So traditionally speaking, absent biceps and inverted supinator localizes to C5, but that is not all in this patient. There are other things also. So.
Yeah. Yes.
But I think it will not be simple MND or simple cord compression.
Exactly.
Some surprise which you are going to give.
Yeah, the clue is that, in fact, I was not keen in diagnosing MND because there is wasting only in the upper limb, no wasting in the lower limb. The tongue fasciculation often is confusing and misleading because don't take any fasciculatory movement of the tongue abnormal unless there is wasting. If there is no wasting in the tongue, you find fasciculatory movements, ignore that. There's a beautiful statement from Raymond Adams which says that such fasciculations without wasting don't give any significance for fasciculation. You must not know when Raymond Adams book when we were studying, that was the only book available in neurology. When the cowl came, Bradley or came, no? Cowl? Yeah. So when we started this thing at that time, only book was Raymond Adams. Then came the Bradley's test book. So he mentioned there are certain key points like this. So that without fasciculation alone don't give much significance. And moreover, he did not have fasciculation anywhere else in the body, even though there was much wasting in this. And another important clue is that if you look carefully, the wasting and weakness is taking the pattern of the root. Because deltoid biceps are maximally affected, triceps is affected. And then the finger flexors are all good power. So that means even the finger, when small muscles are affected, much less affected. Maximum affection was taking the pattern of a radiculopathy. Sensory is not there, I agree with you, but these things should make you suspect something else may not be typical motor neuron disease. Because to diagnose motor neuron disease, it's an untreatable condition. You have to be very, very definite. with only one level of segment element finding. With human below, always think of a localization there, whether sensory percent or not. So these are the 2-3 odd points we have to keep in mind.
Sir, but the patient has wasting of the supra and infraspinatus.
Yeah, that is again C5C6. Supra-infraspinatus are all C5C6.
But he has human predominant spasticity in the lower limbs also, sir.
Correct, you're perfectly right. So we expect if the C5C6, we expect finger pressure to be spastic. In fact, finger pressure is missed on the right side. That is why, as our Professor Kaul said, he has got inverted supinator. When you get inverted supinator, as you said correctly, severe element lesion and body is absent, rest may be brisk. But the common thing is a segmental lesion there, because there is a pyramidal tract below that. That is a reflexive finger pressure has become brisk. So the pyramidal tract involvement is not only confined to the lower limb, but also is there in the upper limb. Evidence is brisk finger pressure. So there is some segmental localization giving you a clue for a localization.
Some intramedullary lesion?
Yeah, it could be intramedullary lesion, but there is no dissociative anesthesia or a pain loss in this patient. Usually intramedullary affecting the anterior console should affect the crossing fibers, and I have seen intramedullary without any sensor. Agree with you. That's not a pretty common presentation. But this can also occur with the extramedullary compression as well. Because the Lebanese involvement is only one segment or 1 or 2 segment. Intramedullary, you are suspected long segment. Suppose small muscles are also affected intramedullary, we expect triceps reflex to be absent, we expect the finger pressure to be absent on the right side, but it's not absent. The most severe affection was on the right side. See, the weakness is more on the right side, I was mentioning all the time. And that reflex on the right side is showing inversion. That finger pressure is this. So every subtle points you have to link it up when the presentation is not straightforward. So that means some suggestion of a localization going in that direction, because the weakness in the distribution of the root. There is some pyramidal lesion below that, the same side as affected. If it is LM and you had expected, that reflex should be lost. And lower limbs is spastic without fasciculation. Even the tongue showed fasciculatory movements, there is no wasting. So these things are all make you suspect that there is something is operating. So this is the rest of the portion of the video. That showing the difference in weakness. Triceps is good power. Deltoid is significantly weak. In fact, we were discussing this particular point. Deltoid is weak. Triceps is okay. So when an EMG was done, thinking motor neuron disease, there was the innervation of all upper limb muscles, and right cortex showed one fasciculation. Other muscles did not change the fasciculation. So what else you want?
EMG of the paraspinal and the lower limbs, sir.
Okay. Lower limb, other muscles are all normal, except for the cortex, you don't want the fasciculation.
But if you find fasciculations in the quadriceps, it says more of MND.
Yeah, but see, only finding one fasciculation is not very important.
Radicular yours.
Yeah, that may not see lower limbs also. I'll come to that. Then even in cervical spondylotic myelopathies, you can have fasciculation in the lower limb. Because often there is a lumbar spondylosis also. They may affect some motor road, can put fasciculatory fasciculations. So always take clinical context also into consideration. There is no wasting in the lower limb muscles. There is no weakness in the lower limb muscles. Then that one fasciculation finding, you don't need not necessarily, you don't keep a significance. Let us say the MRI in this patient. MRI shows, if we cannot make it out, there is ossification of the posterior longitudinal ligament. I'll show the video in all sequences. One more and show. Again, you can find out the bumpy posterior longitudinal producing compression of the cord and multiple levels in the anterior part. The axial cut you can again make it more evident. Again, the cord is significantly compressed, subarachnoid space is all lost here from here. more compressed here in this level. Also, now come to the axial section, which will repeat the compression more better. This is the uppercut, no compression. There is no compression. Little more, just start approaching the cord, just touching the cord now. Now it is see the thickening of the cord, whole longitudinal ligament. Here also is thickened and compressing. This is a much maximum compression here. Here it is not the cord which is more important. It is compressing the entire anterior part, compress the anterior root. That is why probably the patients got element finding predominantly in the both anterior root compression. See this one. Here also you can find out the cord longitudinal calcification. This is lower down. Now it's come back to normal. Again, you can going up now. Again, you can find out the compression there, the anterior part, little more compression there. Here also the maximum compression. And the anterior part of the canal is where the anterior root is coming is compressed. That is where probably the patient not any root pain or any this thing. In ordinary disc collapse, this may not be the state because it may compress the posterolateral disc may compress the root altogether. But a chronic osteotomy ligament calcification can only selectively compress the anterior root or anterior part of the crown. Remember that when anterior compression is there like that, the only involvement in the lower limb is pyramidal because the cord is tethered by the denticular ligament on either side. So when it's pushed, cord is pushed from anteriorly, there may be secondary stress subjacent to the denticular ligament. That is, the part which is subjacent to the denticular ligament is the pyramidal tract. So even though there is an anterior compression, the dysfunction may be only pyramidal because of the secondary stress. So there's no important tract residue in the anterior part of the crown. But the roots are coming out, they can get compressed like this. It's not the one compression, it's extensive calcification. That is why the roots are getting compressed from either side. See here again, you can find extensive horizontal extent is much more than what you used to normally find in a disc. Again, you can calcificate, but here is not much. Here is the one which is here again you can find out the exit. I'll show the video of that patient going down. Okay, now what do you want to do now in this patient? Do you agree with me? Postly, this most likely an anterior root compression by the spondylotic, not spondylotic, the ossificus, the position of the ligament. Roots are compressed much more than the cord.
So we have seen many MRIs with similar, but they don't have significant wasting. So, but he has significant wasting with only mild compression of the anterior roots in the cord.
Yeah, that all depends upon the root compromise. Need not necessarily be due to the compression alone. It can also be due to the canal stenosis and producing ischemia to the root. The compressive element may not be that dominant. Secondly, even in high cervical compression, you can have a wasting extent spanning from CA D1 up to the C5 segment. Significant wasting. And this wasting can even precede the pyramidal lesion, even in ordinary disc compression, C3C or disc compression. They can produce element finding, producing severe wasting, preceding the cord segment. That can well describe it. Next time, if you want, I can show another case similar to showing the wasting with single level compression, extensive wasting. And that's well described in the literature also. There are three postulates for such severe wasting. One is the classical one is the stagnant hypoxia second due to the venous compression. Because the veins are situated intramedullary, they come extramedullary to drain into the maxillary plexus. So they get compressed. The stagnation occurs in the lowermost area where it's starting with that CA segment. But the scheme stagnant hypoxia can extend upward to involve the cranial segments. So the wasting can go up to the scapular plexus due to lesion at C3. C3 can produce wasting of small muscles up to the scapular plexus. And second explanation is antispasmodic compression. And third is the mechanical compression of the root by the thing which I already mentioned. Usually in spondylotic myelopathy, it comes only in 1 or 2 levels. But posterior OPLL can produce extensive anterior compression. And all the anterior compression and the rod is compressed at multiple levels anterior. So if you go back the sagittal cut, see the cord is, see these are all the area where it is compressed. Cord is not much compressed, but it's all getting into the subthecal space. See the cord dimension here, here, here. This is normal. From here onwards, it's supracortical space is not seen. Here the cord is compressed. Here the cord is compressed. Okay, any questions?
One doubt, sir.
Yeah, please.
Sir, actually, I thought this OPLL is a chronic process.
Correct.
But then this patient is presenting like he had difficulty in initially hand dhoti, this thing. Then after that he is not able to elevate the hand within few months itself. So can it occur?
Yeah, it can occur. It can depend upon what is the cause of the neurological deficit. Whether it is a compressive element which is very slowly progressing, but there is ischemic element can be rapidly progressing. Depends upon whatever the pathophysiology of the neural deficit.
Okay, sir. Thanks.
So will he improve with surgery?
Yeah, in fact, here in this patient, surgery, actually, there's some technical problem in surgery in OPL. So I'm not a neurosurgeon, but 2-3 cases of OPL I have sent for surgery. They all did worse. Because, see, spondylotic myelopathy, one level compression is okay. If you remove the multiple level compression, it almost invariably compromises circulation. Because the radicular artery compromise will happen. Because multiple levels you are taking out this, Say, I've seen many people worsening with OPL surgery also. So, in fact, I advise, personally, because of this experience, I told them, anyway, this wasting is not going to improve. We can prevent further progression of the cervical collar. And you're still progressing, we can go for surgery. Anyway, we got a sort, we are getting an opinion from the neurosurgeon, but unfortunately, the neurosurgeon tried to operate. But this is my experience which I have seen. On the other hand, single level disc prolapse is remarkably well with surgery. OPLL always treated, I'm hesitant. Because the multiple A level involvement. Here, what are we to achieve a surgery?
NCS finding was 7.
NCS was normal.
Okay.
NCS was normal.
Sir, was EMG of the tongue done, sir?
In fact, EMG was not that done. Tongue was not done. Only the limb muscles were done. It was Dr. Reggie's case. I don't know it was done. I don't think it was done. But do you think there is fasciculation of the tongue? I mean, even the involvement of the tongue is there. There's absolutely no reason. The tongue movement is perfectly normal. And such in some fasciculated movement don't give any problems.
But EMG can give clue, no, sir. If it's clinically, we are not sure whether fasciculations are there.
Yeah, that's good. That's correct. Maybe you can give definitely a clue. Correct, perfectly right. But we already found the reason there. That's why we will not go further pursue with the tongue.
Sir, the clinical clue is that inverted supinator jerk.
Yeah, that is one important clue. Second is that the distribution, always you look at the distribution of the muscle weakness. It's the maximum distribution C5, C6.
C5. Yes,
That's the point. So that segment is happening. Why in motor neuron disease? That should respect the distribution of the root. So any element finding anywhere without any sensory, whatever it is, the distribution is respecting L5, S1 root or think of radical. Another patient with pure motor, no sensory at all, no root pain, but the weakness exactly L5, S1.
yes,
The disc collapse comes in the root. There's no root pain, no sensory, nothing.
yes, sir.
He was operated and he's doing very well. So the distribution is very important.
Sir, do you expect such a severe spasticity with no cord involvement on MRI, sir? He had severe spasticity.
No, he had minimal spasticity only. But I can see when you look at the patient, how he's walking about, spasticity is very minimal.
വായിക്കാത്തിട്ടെ.
The way you walking. Only evidence is Babinski thyroid sign. There is an early evidence of spasticity. Gait is not spastic at all.
Okay, sir.
Okay. Okay. Any other questions? Shall we stop now?
Yes. Thank you, Madhu. Thank you so much.
Oh, thank you, Suvar. Thanks.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir.
Okay. Bye. Next week.
Thank you, sir.
Yeah, there one more before you leave. I just wanted to mention, because from 16th of May, 23rd, and the next week, shall we start early by about 9 o'clock, 9 to 10:30 rather than 10 to 11:30?
Yes, sir.
Because when the Murthy Sahib has asked me to do another program on those days at 10:30. So I thought I will finish by 10:30 and do the other program, some other teaching course for 3 weeks.
Okay.
Yeah. So anyway, there's still time to go. Then it's only 16th of May, not before that. Still time to go. 2 more weeks we'll do at the same time. Okay.
Okay.
Okay. I will take it.
Thank you, sir.
Yeah. Mansi, are you there? Mansi? Okay.